when I first had a clinician or a nurse or a receptionist kind of see me shaky and sweaty and crying and a total mess, saying I need to talk to a doctor. I can't get off my opioids. And they're like, oh, honey, you need to go to addiction medicine. You need to go to rehab. My mind was like blown because it had never occurred to me that I had an addiction, that just, not because I was like too high and mighty for it. It just wasn't on my radar.
Welcome to Breaking Stereotypes with Todd and Tootsie. Today we are joined by Dr. Travis Rieder, the director of the Master of Bioethics program at Johns Hopkins. Travis is also the author of In Pain, a bioethicist's personal struggle with opioids. In his book and his widely viewed TED Talk, Travis recounts his agonizing struggle with opioid withdrawal following a motorcycle accident that crushed his left foot. Before we get started with Travis, I'd just like to ask our viewers to hit like and subscribe to our channel. It will help the YouTube algorithm and help our new channel to grow.
Welcome, Travis. Thanks for coming on.
Yeah, absolutely. Thanks for having me.
What do you think of the stereotypes of someone who's addicted or dependent on opioids?
Well, I'm glad you asked the question that way, addicted or dependent, because that is, I think, one of the stereotypes. So I guess we should just say, like, from the outset, there are just tons of stereotypes around addiction. And I hadn't thought about them much before my own experience. But so here's two, and then we can talk more. So the first one is that dependence equals addiction. And so we can talk about why that's not the case. And the second is that addiction, and therefore the whole package, dependence, addiction, all of the stuff that goes along with it, is a moral failing. And so it happens to people who are weak-willed, who don't have their act together, who are bad people, who made bad choices. And so we should judge them and demonize them and stigmatize them and criminalize them in our society. So like the latter part, I think most people have a pretty good handle on, that we judge and demonize and stigmatize people with addiction. And then the first part is that we take the symptoms that we see associated with people who use drugs and we put them all in the same bucket and we call it addiction. And so one of those major symptoms is withdrawal. But withdrawal, it turns out scientifically, this is not me editorializing, withdrawal is a physiological response to exposure to various sorts of drugs. And that is to say that you become physically dependent on a drug when you've been exposed to it around the clock in high enough doses for long enough. And then if you take it away too abruptly, the brain, which is this great learning machine, has learned this new normal, kind of is disrupted all again, and you get very sick as a result, and that's withdrawal. What's really crucial about that is that withdrawal happens to everybody who is exposed to opioids or benzodiazepines or alcohol or stimulants around the clock in high enough doses. Happens to 100% of people. Us, everyone listening, anyone exposed to opioids will become dependent and therefore experience withdrawal if abruptly discontinued. A very, very small percentage of people exposed to drugs develop an addiction, because the addiction is the behavioral problem. It is the most kind of non-controversial version is it is continued use despite negative consequences. So it is a behavioral issue. When you cannot stop, you feel like you should, by your own lights you should, and you don't anyway, even if it burns your life to the ground. So those are the two big ones that I can think of.
Did you have that opinion before your experience with them yourself?
This is a really interesting question because, so I did not think that dependence was addiction, but that was because I have experience with antidepressants. And so antidepressants are an easy way to prove to people that being in withdrawal doesn't mean you have an addiction, because most antidepressants are SSRIs, or most of the popular ones are, so selective serotonin reuptake inhibitors. And SSRIs cause physical dependence, which is to say, if you take them away too abruptly, you send the person into withdrawal. But no one is addicted to SSRIs. They are a non-addictive drug, because the thing that drives addiction is cravings. is euphoria, is chasing goodness. And SSRIs, and as anyone who's on them can tell you, are not euphoric drugs. As a matter of fact, the benefits are kind of backloaded and the negative side effects are front loaded. If you just start SSRIs, they cause a bunch of kind of nasty side effects, right? So no one craves SSRIs, which is why they have no street value. There's no black market for them, et cetera. Mm-hmm. So I've had experience with SSRIs, so I know what withdrawal is. And I had just like internally, without ever having thought about it, like, oh, people can get withdrawal. It just means they're sick. So then I had this experience where I was, exposed to opioids and discontinued badly and developed withdrawal. And it never occurred to me that meant that I had a problem with drugs. I was just sick in the same way, when I missed my Lexapro, I was sick. And then when I first had a clinician or a nurse or a receptionist kind of see me shaky and sweaty and crying and a total mess, saying I need to talk to a doctor, I can't get off my opioids. And they're like, oh, honey, you need to go to addiction medicine. You need to go to rehab. My mind was like blown because it had never occurred to me that I had an addiction, that just not because I was like too high and mighty for it. It just wasn't on my radar. So I had this kind of weird exposure that meant I didn't have that particular stereotype. But to this day, I get emails from people who watch my TED Talk or read my book, and they tell me they have an addiction, but their only evidence for that is that they go into withdrawal when their doctor cuts them off from pain meds. Wow. And so we have to step back and say, even with your first personal knowledge of what's going on, I have people say, I can't believe this happened to me. I'm hooked on opioids. Like, what do you mean that? But, well, my doctor cut me off and I'm sick as a dog. Like, well, you might be hooked on opioids, right? Let's talk about it, but that doesn't mean it. And then the moral failing one, not at all. So, my day job is I'm an ethicist, right? Mm-hmm. Addiction's a health issue. I work in health policy, and I have addiction in my life. I love people who have problems with drugs, and I know that they have a health problem and that medicine can help them. But the moral failing model is dominant in our society. So I certainly have absorbed that one, even though I know that it's wrong.
Yeah. Can I give you a little bit of a personal experience? Because this is kind of surreal, actually, talking to you right now, Travis, because I actually went through a similar experience that you did. But it was only a year ago. And so I tore both tendons on my biceps while working out. And so I had to have surgery pretty quickly. I was put on really high doses of opioids, and then the surgeon just completely discontinued them. And so I went kind of through a very similar experience than you did. And actually watching your TED Talk and sending it to friends and family was something that you were able to articulate kind of what I was going through much better than I could have at the time. So they really kind of got it because of how powerful that TED Talk was. But I also, and Tootsie and I were discussing this yesterday, was dating somebody at the time who is a nurse practitioner in urgent care. And she told me, first of all, when I told her about kind of what I was going through, she said, just be a man and get through it. And then she said, are you telling me this because you want me to prescribe you opiates? And I had to end the relationship because of that. But this was something that was in the field. And again, we're talking about February of 2021. So luckily, my own private physician came and helped me. But it was this intense taper that lasted only 2 weeks. So I'd gone from, I believe, 80 milligrams of Oxycontin a day down to 0 in 2 weeks. And each step I went was just inviting more hell. And, obviously you know that. But I guess the thing is that it's still to this day something that is going on despite all of the changes. Because, in your book, you described how the pendulum kind of swung from one direction to the other as far as over prescribing and then, kind of not utilizing them at all. But I don't know if it was because of the fact that I was this white male, but the doctor just said, here's this big bottle of opiates, take them as you need them. And I was really just uneducated about, kind of how powerful they were. And there was no plan at all for tapering. And when I contacted him and I said, what are we going to do next? Like, I'm really sick. He said, I'm sorry, like, there's nothing I can do.
Yeah, it's really awful at how common that story is. So you can imagine, right? Like, it's slowed down now that, the TED Talk is several years old, but for a couple of years, I got, a dozen emails a week from strangers who were going through similar experiences. And of course, I would get a lot of emails from people who have an addiction, who have a substance use disorder, and they were also looking for the same sorts of help and resources. But a lot of people were just telling me these basic stories, right? Like, the most common one is I had a surgery. And so, big back surgeries, like sports injury or skiing surgeries, like pretty traumatic surgeries, big incisions, like hip and knee replacements, right? These are really painful surgeries where, surgeons have for decades now just prescribed bottles of opioids because they would much rather you have more than you need than to come back into their office and need more. The reasons for that are awful. Like, there's this very detailed reason, which is that when you have surgery, there's something called a global plan that says that for some number of weeks after the surgery, if you come back in, the doctor's office doesn't get to charge you again. So if it's like an update from that surgery, if it's a check-in, you don't have to pay anything and they don't get to bill it. And so they really are disincentivized from having you come back in for one of these, short sorts of needs. So give you a big old bottle of pills and then you won't be calling them in the middle of the night or coming back in.
Mm-hmm. When you were describing, dependence and, you explained it so well that it's just, 100% of the people this is going to happen to, it's, science. And you've said in your book, like, what happened to you was entirely predictable. And so, I guess it begs the question, why does this keep happening when it's literally setting people up for this type of reaction?
The causes are just myriad, and it's structural and it's individual and it's educational. But a really big one is that physicians aren't trained in pain medicine, trained very, very little. And so when I was researching my book, which is now 5 and 6 years ago, the most up-to-date data we had was actually from Johns Hopkins, where we had a survey of medical schools, and the median number of hours spent on pain medicine was like, I don't remember the exact number, but something like 8. So you get like 8 hours of pain medicine education in your physician education career on your way to becoming a doctor. And so I would explain this and tell it to doctors, and my doctor friends would say, well, that's okay because that's what residency for. That's what being on the wards is for. This is like an apprenticeship model. You're learning from other doctors. The problem is they never learned it either, right? So at Hopkins, we've instituted an actual pain course, which is taken to be pretty aggressive because this is not a requirement from, graduate medical education accreditation. And so we do this thing that we're kind of proud of, and I lecture in it every year. I get them on the last day of their first year of medical school, but it's a week. So they have 3 hours a day for 5 days, and then I get them for the last, hour or 2 hours of their M1 year. But that's it. And that's M1. They're going to have 3 more years of medical school, and then they're going to have residency. And they get all of it. They get pharmacology, pain pharmacology, addiction medicine pharmacology. They're getting, basic biology. They're getting like a little bit of ethics for me and patient experience. They get all of that in 15 hours. And that's the entirety of it. And it's totally optional. And we're seen as like a pretty good example of what pain education looks like. So the basic reality here is doctors don't know much about pain. And we have a kind of Dunning-Kruger thing going on, right? The less you know, the more you think you know, where they actually think they know how to treat pain pretty well. And so this has come about not through their fault. It sounds like I'm beating on doctors, but this is institutional stuff, right? Mm-hmm. We let a lot of this education come from pharma. So we let pharmaceutical reps come in and do the education, and they were sold a bill of goods about, this is how easy it is to treat pain. Now, to be clear, in the era of the drug overdose epidemic, a lot of people are now afraid of opioids. But think about the fact that surgeons still have to use opioids. This is a really important acute pain medication for severe acute pain. And they all learn from the pharma reps who came through their office and told them about how to use it, right? So huge educational deficit. So pain is super complex and we don't teach about it. And opioids are really complex medications. And doctors were told that they're not, that you can prescribe them like antibiotics. You write the prescription, you hand it over, and your job is done. But that's not true because they cause physical dependence. They have, misuse liability, which is to say they can cause problem drug use and eventual addiction. So really complicated drugs that have to be closely monitored. And the only people who get training on how to do that are addiction med doctors. Guess how many of them there are, right? Mm-hmm. Not many. So just tons of structural problems, and we're nowhere close to solving it, as your experience unfortunately shows.
Yeah. Well, one of the things that I really liked in your book as well was you had a tapering program. I don't know if you developed it or you developed it in conjunction with others. That would be something that all doctors would have. I'm wondering, though, how practical is that for surgeons, for example, who see, who operate on patients, 3-4 a day or whatever, versus, having some kind of a system that you could transition after surgery and then all of a sudden be in a place where you have pain management and have that tapering plan that they can kind of oversee and manage versus the surgeon, for example, in each specific case. I would think there'd be a big market for that.
Yeah, well, there's a lot going on there. We don't have anywhere near the infrastructure for pain medicine to actually have pain docs take care of all this. Pain medicine is a really rare resource. And so, for instance, at my institution at Johns Hopkins, we now even have something called a peri-op pain clinic, which is filled with specialists in pain addiction psychiatry who really know how to taper anyone, kind of no matter how complex their case is. And I'll talk about the complexity in a second. But that's a kind of one-of-a-kind program. And who's getting in there are really complex patients. So a patient who comes in on a really high dose of methadone that they've been on 7 years for substance use disorder, who needs surgery, and that level of methadone is going to cause trouble for them in controlling their pain after surgery. So they have to taper down in order to have surgery and then recover. That high level complicated case is who these folks are specializing in. Mm-hmm. And so, a tiny fraction of a fraction are getting really expert access here. So to answer your question, in a lot of routine cases, so I call these the cases of routine dependence, I could taper you. I'm not an MD, a PhD in philosophy, right? This is not my freaking job. Uh-huh. But now knowing what I know, having done the research, having worked with doctors for the last 5 years, having developed some of these tools with them, I could taper you after your surgery. Your case, pretty straightforward one.
Sure.
Here's the actual truth for you and for me. So you had these bicep tears. I had my foot crushed in a motorcycle accident. These are traumatic injuries that require emergent surgery and a pretty long, by surgery standards, recovery time. What that means is just that you're predictably going to be on opioids long enough that your brain develops physical dependence. You know that in advance. You recognize the trade-offs. So you actually minimize some of that opioid use, right? So my guess is, without knowing the details, my guess is that you shouldn't have been escalated to 80 milligrams of OxyContin. That's a pretty high dose for a fairly routine post-surgical recovery. I definitely should have been escalated. I was escalated to 120 or so milligrams, and for months, that was irresponsible. So you do some of that forward-looking stuff. you make the trade-offs, you suffer a little bit more pain, which is a real trade-off, right? It's a legit consideration. But you do it because this is a devil's bargain, right? The more pain you relieve, the more pain you have at the back end with the tapering management. And then in these pretty routine cases, the only secret to tapering is you do it slow.
Yeah.
Like if your doctor had said, instead of 2 weeks, we're going to do this as slow as it takes to minimize your withdrawal symptoms, maybe that takes 2 months, maybe it takes 4 months, which would be strange for a relatively standard post-surgical recovery. But if that's the way it happens, because the name of the game here is patient-centered care, that's all you do. You slow it down, and it's easy. And then there's a gradation of complexity from there. And so the sort of tapering that I train doctors to do on a regular basis, it can fit on a bookmark. So it's for surgeons, for primary care docs, for people who routinely prescribe opioids in a high enough dose for long enough that dependence will be a concern, but it's predictable. And then there are the hard cases. There are the cases of cancer, sickle cell, chronic and chronic to acute pain, just severe chronic intractable pain from other conditions. And it gets kind of more and more complex. And there are patients who have been on opioids for decades because we use them so aggressively. So we call these patients legacy patients because they are a legacy of this past really aggressive opioid prescribing pattern. And if a patient's been on opioids for 22 years and they are on thousands of milligrams of morphine, then they require a specialist. That's not a thing that I could train, a surgeon how to do. That's who goes to the pain specialist or the tapering specialist, because we have such a small resource. We use them for the most complex cases. But surgeons, and to be clear, surgeons are not going to do this work. So I work with some surgery hospitals. I've done some advising, and they're super straightforward. They're like, our surgeons are not going to taper patients, but you've convinced us that it is our responsibility as an institution that it has to be done. So how could we meet our obligation? Totally fine. You're not going to, your $400,000 a year orthopedic surgeon isn't going to taper patients. Train up a team of nurse practitioners or PAs. They can absolutely do this job. They just have to have prescriptive authority and the knowledge of how to do it.
Yeah, makes sense for sure. So just to go the opposite end of the spectrum, talking about legacy patients and you being, a bioethicist, what's your thoughts about, people who are in that kind of chronic pain that, why not just have them be on opiates for their entire life? If it manages their pain.
Yeah. So the shortest answer to that question is maybe they should, right? Okay. It's totally possible that the answer is, maybe they should. But the other answer is we should be super honest that opioids are not always great drugs. So they're really good drugs for your case, for bicep tear and surgery, right? They're really good case for my case for surgery and series of surgeries. And they're really good drugs for palliative care, for end of life, for severe cancer pain, right? But the evidence is incredibly mixed on how good a drug they are for various sorts of chronic pain. And the reason for this is opioids have a lot of side effects. So I don't know how you experienced them when you were on them, but I wanted to be off opioids. I needed them because life without them wasn't worth living from the pain. But the constipation is awful. And you say that and people are like, oh, constipation, come on, give me a break. That can be life limiting, right? It can also cause emergent surgery, right? You can have serious blockages. But the sedation, right, can make it so that you have serious memory problems. You don't have the energy to do various things. So all of this stuff can be managed in different ways. But what's really important is that there's pretty good evidence that long-term opioid use actually causes more pain. So there are lots of theories about this. It's unclear what patients fit all different models. But we have pretty good evidence that a lot of patients who are on chronic opioid therapy are no longer actually benefiting from it. But you can't know that unless
You take them
you
away.
get them off, you get them through withdrawal, and then you see, is their pain better or worse, right?
Yeah.
Now, you can imagine that feels like a terrible bargain to somebody who does actually feel like their life is pretty manageable on monster doses of opioids. But the last time they experienced life without opioids was decades ago. They don't have any idea what their life would be like without opioids. So if it turns out that the vast majority of the pain that they're experiencing is actually caused by the drug that they're taking, well, what in the hell are we supposed to do about that? So I wrote an essay for my colleagues in the scholarly literature and AMA's Journal of Ethics, arguing something that did not make my doctor friends very happy, because they almost uniformly, they're big, obvious exceptions, but the vast majority of physicians believe that it is their judgment about whether a drug should be given. And so when they are told or convinced that the risks outweigh the benefits, it's their job to take the drug away. That's kind of the job that they're given when they're given prescriptive authority. You have a DEA license. Your job is to safeguard these substances for society, right? But the problem is, we, medicine, society, the judgments we made, we put these people in this very vulnerable position to where now they're damned if they do, damned if they don't, right? And so my argument is the only way that we can navigate out of that is to give them agency in deciding which direction that they go. And so I do believe, I spent a lot of years looking at the evidence. I've served on the CDC committees. I've served on NIH committees. I've looked at this with world-class experts. I do believe that most patients would probably benefit if they could get off of the opioids that they were on, if they're on these really high-dose long-term opioid therapies. But my judgment about that actually just doesn't matter very much, right? Because they're in this really vulnerable position where they may be suffering those side effects, but that was because doctors put them in that position. And the only way to find that out is to go through what can be a hellish, very long withdrawal process. These withdrawal processes, these tapers can take years. And so I think they're entitled to a say in their care. So the short answer is, I think doctors don't have unilateral authority to discontinue opioids from these legacy patients.
So you learned everything the hard way, obviously. And I guess the question is, because it sounds like the best chance anyone has is to actually know this information in advance. In the event that something happens and, your life was changed in an instant, how could you have been, educated on this previously? But do you think that had you known then what you know now, you could have affected your care in any way by being a stronger advocate up front? Keep in mind that you're totally in pain and drugged out.
Right. So the answer is yes, but like heavily, heavily caveated. Let's not victim blame anyone, right? So like the answer is yes, but if this is you, it's not your fault. Right? Like if this is you, the system should have taken care of you. And now if the only chance that you have to save yourself is becoming educated and empowered, well, that is just a really awful system. Right. So with that caveat, the answer is yes. And I know this about myself because I ended up having to have another surgery on my mangled foot after I went through withdrawal. Right. So I got hit by a motorcycle, blew apart my foot, had 5 surgeries over the course of a couple months, and then went off the opioids, went through this terrible, terrible extended withdrawal, and finally made it out the other side. But I wasn't done yet. I was kind of actually in a waiting period because you have to wait months for the edema, for the swelling to go down before you can have the final surgeries to see if you can like shape the foot again, because you have to know what it looks like basically. So I had to wait about 6 months before I could have the next surgery to see if I'd ever like fit in a shoe and walk and blah, blah, blah. Well, you can imagine after my experience with opioids, I did not want to have another surgery.
Right.
Of course.
And so I initially actually called it off. I told my surgeon, no, I asked this, so this kind of surgery is done by plastic surgeons who are not just butt tuck people, right? They help reconfigure damaged body parts. So I asked my plastic surgeon, like, is this cosmetic so that my foot is vaguely foot shaped? Or is this actually important? And he said, oh, it's mostly no. He told me, no, this is important. Like, you won't fit in a shoe, etc. And I said, I want a second opinion. So I went to my orthopedic surgeon who'd put the foot back together. And he said, look, you escaped all of this. It's amazing you didn't get, bone infection, which would have been catastrophic because I had bone exposed for weeks. He said, you really want to carve your foot open again? Like, this is healed. Leave it alone. And so I went back to my plastic surgeon and said, I'm done. And he's like, no. I'm going to call your other doctor because he doesn't understand. If you don't get good footwear, it's going to affect your hips. It's going to affect your gait. You're not going to be able to walk again. You won't be physically active, which will make the rest of your health decline. It turns out that was a very good argument. Like, he was correct about this. So I ended up deciding I needed to do the surgery, but I was terrified. And so it was only at that point, it's a bit of a backwards way of telling the story, but I mean, I'm a professor at Johns Hopkins. I have access to world-class information that I never took when I was like going through withdrawal and clearly internalizing some of the shame associated with drugs. I never reached out to any of my colleagues, any of my friends. But now, having got enough space and being scared of this last surgery, I finally start strategically reaching out to some of my colleagues and saying, do we know anyone in pain medicine? And that's how I got introduced to now a really good friend, Michael Erdek, who's a great pain doc at Hopkins. And, it's the sort of thing that, like, what he really did was he gave me common sense advice, but it came from somebody with authority and it helped me understand. And he had lots of technical things that we could do. And so one of the things he suggested is he wanted to put me on a drug called gabapentin ahead of time. And there's evidence that this lessens pain and decreases the amount of opioids you need. But I'd actually been on a gabapentin already before. And it was so mixed up with my trauma that I was like, no drugs. Like, that still causes dependence. It actually still has misuse liability. Like, no. And so I finally just asked him, like, can I do this without opioids? Can I have them carve up my foot and just suck it up? And he's like, look, I mean, can you? Well, of course you can. Like, people existed for thousands of years without opioids. Like, it's physically possible.
That sounds like Revolutionary War stuff, though.
It's like, yeah, I mean, people also just like died all the time. Like, yeah, people had surgery without antibiotics too. Didn't go well, right? I mean, his basic thing was, you don't have to. Like, yes, that's possible, but if you're really scared, here's what you can do. We can ask. I can advocate for you. We can ask for low dose hydrocodone. It's a fairly weak opioid compared to oxycodone or especially hydromorphone, any of these others. It's pretty modest. You ask for small tabs, 5 milligram tabs. So really take ownership here, right? He's telling me. And then you take them when you absolutely have to and no other time. So part of what he was teaching me there, and he wasn't giving me the full science lesson, but we would backfill later. He helped me with my book, and he helped me fact check and teach me. Part of what he was telling me was dependence happens when you bathe your central nervous system in the drug. It's there all the time, and your central nervous system basically never has an opportunity to go back to its base state. So it's around the clock and for an extended period of time. So one of the things that you can do is not only use a lower dose and not more than you need, right? But also just like only when you need, so that you have these kind of drawn out periods where, yeah, it hurts and it sucks, but your brain is like, no, I get to go back home. I get to go back to homeostasis. And the next time you take an opioid, full experience again, right? Now, it's not quite that simple. If you're taking it every 6 hours, every 8 hours, every 10 hours, you're still developing little bits of dependence, but it's not the same as when I was on IVs for 24 hours a day, right? And then the other thing he said is get off as fast as you can, right? So you take pills when you need them. The first few days, that's going to be every 4 hours. The first few days are awful. Surgeons carve. That's their job. But after about 3 days, you will notice a difference. It will still suck to be alive, unmedicated, but it will suck less than it did the day before. And as soon as that happened, you start stretching it out. Mm-hmm. And every day it's going to get a little bit easier. But here's the thing. When you need to sleep, you're going to still need them for a little while. And when you need to do physical therapy, you're going to still need them for a little while. Mm-hmm. But stop using them when you can get away with not using them. If you're sitting around with your foot up under ice, watching TV, distracting your brain, turns out distraction totally works, right? Don't take a pill, right? Start to use that time. This is all just super sensible advice, mm-hmm. and it absolutely matters. And so that last surgery was way more painful than any of the first massive 5 reconstruction surgeries. It was more painful because I did not medicate myself as much, right? Mm-hmm. It still took me 2 weeks of taking the hydrocodone, but I wasn't taking it around the clock, and I was getting less each day. And at the end of those 2 weeks, I was only taking it at night. And when I stopped taking it, absolutely nothing happened. No shakes, no sleeplessness, no nausea, no vomiting, not a single symptom, right? And for me, that was like the moment of realization, because nothing magic had happened between the other surgeries and that. I'd had a little bit more information. I'd advocated for myself. And that was like when, these drugs are not evil black magic, right? So if I found myself in an emergency right now, I would absolutely take opioids, which blows people's mind when they hear my story.
Sure.
But no, like, they're incredibly good acute severe pain relief, but I would also know how to minimize my chance of being tortured down the road.
Yeah, absolutely. Unfortunately, though, I hate to say it, it sounds like that sucked comparatively to just getting your pain managed and then going through a taper. Do you know what I mean? I hear what you're saying, but it's something that I'm wondering, kind of if the average person who wouldn't have that knowledge, and I think that's where you play such a strong part as far as education, like with your book, as far as, like getting people to the point where they have an understanding that if they have a surgery, if they don't want to get dependent upon opiates, they're going to kind of have to take the route that you did on your last surgery.
Yeah. So here's the crucial knowledge that I had for that last surgery, that every moment of withdrawal was the worst moment of my life. And that meant that I was willing to pay a lot to avoid it again. Mm-hmm. And that's really hard information to convey to other people, right? Mm-hmm. So what I was able to do is I was able to make a cost benefit analysis, mm-hmm. with all of the relevant costs and benefits in mind. And the only way I got there was by being tortured for 30 days, right? So it's not a great situation. It also means that one of our solutions to reasonable and responsible pain care is, when we use opioids, we have to really teach people about the costs and benefits so that they can do their best. It's not going to be the same if they haven't experienced it, but they can do their best at actually making an informed decision. Because when we do medical interventions on people, here I'm a bioethicist, right? So teacher mode coming out. When we do medical interventions on people, we require informed consent, right? Like, the things that doctors do to us are not allowed with normal people without, right? Like, what makes it medicine and not assault is that it happens in a doctor's office, and I gave them my fully informed consent, right? And we've always pretended like opioids don't actually need much in the way of consent. Like, they're just simple meds that, like, here, you obviously want these for an extended period of time. But it's a costly intervention, so we need to educate people about them.
Yeah, absolutely. Well, it's something that, again, when I watched your TED Talk while I was kind of in the throes of it, it was something that I think the only people that really can get it are people who are going through it, because it's something that I really felt like I was going to die. That was the closest that I felt. And I know that sounds, I guess like hyperbole, but it was really kind of, there was no, kind of relief, no sleep. It was just completely terrible. And I'm not married, or, and so it's one of those things where I was doing this completely by myself. And so I really, and the irony is that I got so pissed off, to be honest with you. Like, so with the last taper, I just said, fuck it. Like, I'm not gonna do it. I'm just going from, I think it was like 2.5 or something. Like, it was 5 to 2.5. And I just skipped the 2.5 and I said, I'm just going to get through this. And I did, but it was hell. And it was something that, coming through on the other side, I was actually scared of the pills. Like, if I saw them, it would actually create anxiety for me. And so now it's something where I'm like you, like if something really bad happened, I would go on them again. But it's one of those things where I would never want to go near them just because of the fear that they instilled. It's just, it's interesting if you haven't experienced it.
For sure. Yeah.
So whose responsibility is it as far as all of it? Whose responsibility is it to educate? Whose responsibility is it to implement a tapering program? Like, it feels like, there's this big gaping hole that it's all falling through.
Yeah. So
it's a big question.
Yeah.
Yeah.
It's yours, Travis. Your TED Talk is doing it.
Career. Yeah. So the way I got invited to give that TED Talk was I had published a paper. This was just like the weirdest thing, right? So this was not my job. Prior to the motorcycle accident, I did like climate change ethics. I still do climate change ethics. I work on food sustainability, overpopulation, resource limitations, moral philosophy. I knew nothing about pain medicine, nothing about opioids, drugs, addiction. Now that's been my life for the last 7 or so years. But what happened as I recovered, from the accident, but also just from like the trauma of going through this experience, is I slowly started to share my experience with trusted people. And I do have access to an important network of scholars. And so I finally had one very good friend, just a really incredible guy. Who's also just like one of the baddest of asses in academia, who said, look, there's a health policy journal, it's one of the leading health policy journals in the world, super high impact factor. And they have a storytelling column. If you can tell a narrative that has policy implications and do the analysis, this column called Narrative Matters. The journal is Health Affairs. He said, if you could bring yourself to share this, I bet it would help a lot of people. And super important advice. I had no idea whether I would ever actually do this, but I started writing. And it took a long time. So from that meeting with him to publication in Health Affairs was over a year. And I kind of thought it was my thing. Like, it was done. Like, that was my contribution to this conversation. Maybe no one would read it. Maybe like a few doctors would use it. And it was just like crazy when it came out. It blew up. It was one of the most read articles of the year. And so then I got invited to give talks. And I didn't know anything other than what I had discovered in my like year of research for this, which, for an academic, like, I spent 10 years researching my other fields. Like, I was still a baby when it came to this. And so I'm like scrambling to develop some sort of expertise. But the argument in that first journal article was very simple, because you tell a story, make a health policy argument. And the argument was really simple. It was, in our current medical structure, we allow clinicians with DEA licenses to prescribe a medication that they don't know how to deprescribe. And that's clearly wrong. Now, I went with a really short line between that diagnosis of the wrongness to, a kind of conclusion. I said, so that means that if you're a clinician and you are prescribing opioids, it's your responsibility to know how to deprescribe them and to be willing to do the work. Because to be honest, this work isn't fun. It's not good. It doesn't reimburse well, right? Like, this is hard, undervalued work in the healthcare system. And so I was just like, hey, docs, stop doing this part of your job badly. And to be fair, I actually still stand by that with in a lot of cases. Like, I think that a lot of clinicians, nurse practitioners, PAs also fall in this, anyone with prescribing authority. I think a lot of them, this still actually applies. You think about family medicine, the small town doc who kind of does everything. Like, if you have been prescribing opioids for people who come in with ankle sprains and broken bones, and you prescribe enough for them to get dependent, which, P.S., those are typically not the cases that you should prescribe that much, but then you're on the hook. So you become morally entangled with them. Your actions put them in a vulnerable position, and you have a standing relationship with them, right? It actually falls apart in the really complex healthcare system outside of that, though. So we already talked about surgeons, right? Surgeons are special. They do this one thing. They come in and they cut and they fix and then they leave. And all of the rest of your care is outsourced to a variety of team members who do. So I don't think a single surgeon signed any of my prescriptions. So, when I was writing the book, I went back and requisitioned my medical records, and I had something like a dozen prescribers over 3 hospitals and 6 surgeries. But I don't think a single one of them was a surgeon. So these are largely PAs. PAs are running the ship in these big surgery centers or hospitals. And so that means we actually just need to develop a sort of institutional plan. And I think that's okay. So if our model is going to be that a surgeon is like the captain of the ship, they do their thing, well, then it's on the hospital execs. It's on the C-suite. It's on the policymakers in that institution to figure out how to solve the problem. But it's somebody's job. So that's the consequence, right? Here's the thing that's still true. It cannot be that our system for care is to have clinicians prescribe medications that they don't know how to or aren't willing to deprescribe. That's what can't happen.
So I'm really interested in how you're doing and your foot's doing at this point.
I'm so insanely lucky. We didn't talk very much about the accident, but it was gruesome. It was a horrible, horrible accident.
Yeah, it was really hard to get through that chapter, to be honest with you, just because you did such a good job describing, but it was horrific, really horrific. And so, but yeah, sorry, keep going.
Yeah. So I actually wrote a totally different paper with an orthopedic surgery colleague who became a good friend. She did not do any of my operations, but she helped me afterwards. And she and I wrote a paper arguing that in a lot of cases like mine, we shouldn't be so quick to try to save the limb. Our frame of limb salvage puts us in a context where we think that like the good and right thing to do is to save the limb. And that means that we take on a huge amount of costs for it. But there are a lot of cases like mine where there's genuine uncertainty in the recovery odds for amputation and good prosthetics versus long tortured reconstructive surgery sequence. One of those big costs is pain care over a long tortured reconstructive surgery sequence. So it's very likely that if I knew then what I know now, I would have told them at surgery 1, take the foot. Wow. They probably could have gotten away with what's called a transmetatarsal amputation. So I get to keep some of the foot as basic structure. But like, I didn't have that option. I went through all the tortured stuff. The recovery was years long. I walked, with a walker, used a knee scooter, eventually went to crutches and a cane. I was walking with a cane for a couple of years. But my orthopedic surgeon, this first week in the hospital, said, you'll probably never walk again, right? Like we might be able to save the foot, but if we do, you'll probably never walk again. So now I rock climb. So I'm kind of like,
Wow.
I don't know if I'm
awesome.
allowed to flip off the camera for this podcast, but it's like my kind of response is, yeah, like I won. Everything is everything's extra because I'm active with my daughter, and we just went out west and hiked in the Grand Canyon, and I rock climb 4 or 5 times a week. So that is not to say that I don't have like chronic pain, which I do. And I have dissolving joints fused in my foot, which eventually will give me so much arthritic pain that I have to have more surgery to take them out and fuse bones and put in metal plates and screws. So like I've got a long-term problem with my left foot, but I'm doing very, very well. Thank you.
Well, yeah, I'm really glad to hear that. The other question I had is, did your wife say that you can't ride a motorcycle ever again?
So here's how that went. So Sadia, my partner, would never say you can't do X. Not the way our relationship works. But I like being married. So there was never a world in which I was going to get back on a motorcycle. It took me 4 years before I was willing to try out a bicycle. Because during my recovery, a lot of conversations with friends, physical therapists, doctors went into like, how can I stay physically active? Because it's one of the things that I feared, right? It's like the more your body breaks down, the less active you become. The less active you become, the more your body breaks down. This is the vicious cycle. As I'm now middle-aged, like I think to myself, this is how death happens, right? So I want to stay physically active. And those years it hurt. And so one of the things so many people told me is bicycle, low impacts, right? Like if you can get enough flexibility in your ankle to get around, bicycle. But being on 2 wheels was terrifying. So, you talked about how, the anxiety of seeing the pills. I had that too, by the way. But I have a lot of anxiety that come from 2 wheels. So I still flinch when motorcycles go by. So bicycling even took me a long time. So it turns out that my fear of divorce did not have to do the motivation.
Well, but the other thing that, you talked about, which I think is really important that we really didn't touch on, is that, going through these kinds of experiences not only affects you, but like you talked about in the book, it affected Sadia. And because she was having to take care of your daughter and help you because you didn't have the ability at that point. And so, her mental health must have suffered just from worrying about you. And do you know what I mean? So there was so many more people that were affected by this than just yourself.
Yeah. I mean, there's so much to say about that. So one, I think in some ways it is harder for her to revisit that time in our life than it is for me, because to be honest, a lot of it's gone now. The process of writing the book was a lot about consulting the notes that I took. So I got very good advice early on in the hospital to take good notes. Although my notes were often funny because I was so high. But then Sadia was like my external memory, right? So medical records, notes, and her. And I don't think she would do like the amount of speaking and interviews and stuff that I've done in the past years. I don't think she would do it just because I've now gotten to the point where, I mean, you saw my TED talk, I about lost it on stage there. So like every once in a while it comes back and it's like real and it's traumatic again. But I've now been doing it for so long. It's kind of like it happened to somebody else. Right. But yeah, I mean, I lost a lot of the memories of that first year from the drugs, from the trauma, retroactively just gone. I was unconscious for a bunch of those first months, right? So it was really like so much of the actual trauma was was hers. And then we've talked a lot in this conversation about pain medicine. So the role of opioids in pain medicine, bad withdrawal care, et cetera. But of course, like, this is all connected to a much broader conversation, which is that opioids are addictive drugs that are playing a huge role in North America's drug overdose crisis. People do have very serious problems with these drugs. And so there's this whole other literatures, of addiction medicine and public health of the overdose crisis. So one of the things that was happening during my withdrawal experience is that I was being taken care of, right? So you said that you're not married and you had to go through this alone, and that made my head explode. Because if I had been alone, I would have gone back to the drugs, and I don't know what happens in that version of the story, right? And that's one of the most important lessons that drove me to eventually do this work, because to be super clear, even though I said I've like gotten kind of detached, doing this work sucks. Like, it's hard. It will always be hard. It's emotionally draining. I spent 4 years going around the country giving talks. Like, after the book came out, I gave 2, 3, 4 talks a week. And people want to hear the story, and I want them to hear the story if it's going to be helpful. But it is hard to do. And there are a few key points of my like thinking about my experience that convinced me I have a real responsibility to do this work. And one of them is I am like the luckiest person in the world, and I still barely got out of this, right? And so just like, let's just run down the list, right? I'm a man. So what's that mean? It means my testimony in medical situations is taken more seriously. This isn't editorializing. We have evidence about this, right? I'm white. What's that mean? My testimony in medical situations is taken more seriously. I'm less stigmatized when it comes to drugs, blah, blah, blah. But then also, I have this incredible partner who just dragged me. I mean, crying and kicking and screaming, just carried me through the whole thing. And there's no way I'm doing it without it. I had a 1.5-year-old at the time. I was desperate to be a good dad, to return to that life. I had just gotten a job at Johns Hopkins as a professor, right? Like, I had everything in the world to work for, to live for, to return to my life for. I had all this support. I had access. I didn't use it at the beginning, but I had access to the kinds of information and resources that virtually no one does. Sadia is a research scientist. Like, she was spending her time trying to solve this problem on her own since nobody else would. And I still was, on an absolute knife's edge about whether this just ruined my life or not. Mm-hmm. So here's the question. What happens to everyone who has none of those advantages, right? And the answer is clearly, was my guess, but also now that I've done the work, I've heard from all these people, the answer is that they fall through the cracks and they suffer. And some of them go on medication that's not good for them, and that's a form of suffering. Some of them develop use disorders and then go through all sorts of other hurdles, right? Like, some of these stories end in death, end in drug overdose, end in suicide, and in homelessness, right? The amount of good fortune that I had is so unbelievable to me. That shouldn't be what it takes to survive medical care.
Because of all the privileges that you just outlined, it's something that, you're absolutely correct that if it can happen to you, it can happen to anybody. But because it happened to you specifically, it's something that I really believe has been a godsend for everybody, just because of the fact that you're able to tell your story, articulate it in a way that really drives home how powerful this is. And it's something that, again, I can't thank you enough from just reading your book and watching your TED Talk and now having the privilege of talking to you today, as far as, because, when you're going through it and you don't have this kind of education about it, it's something that first of all, you don't even know if you're going to make it. That's, and then, so when you said, I remember in your TED Talk, you said, you kind of did what I did. You said, I'm not going to take it. And then the next day you finally fell asleep and you didn't have the cravings as much anymore. And I kind of experienced something similar, but having that information was something that said, I can do this. And so I'll forever be grateful for you for giving me that information.
Well, thank you. That is very, very kind, and is very helpful whenever I'm tired. It's very helpful to hear and believe that. So thank you, truly.
Yeah, well, we thank you so much for coming on today, Travis. We invited you on because we strongly believe you break the stereotype. And we would like to ask our viewers if they think that Travis helped break the stereotype of opioid dependence and withdrawal. Drop a comment below. Be sure to like and subscribe to our channel for more in-depth interviews that break stereotypes. Thanks so much for coming on, Travis. We appreciated your time today.
Yes, thanks again. Really appreciate it.
Talk.
Thanks for having me.